Hello, everybody, and welcome to tonight's Care Virtual Information event. My name is Charles Kingsland, and I'm the Chief Medical Officer for Care Fertility, here broadcasting to you live from the banks of the River Mersey in Liverpool. Now, in the background, I've got all my friends and colleagues, Jess and Alison and Emma, Chloe, who are taking questions. So if you want to email us and ask any questions this evening, we'll have two sessions where I'll answer as many questions about IVF as I can. And if we run out of time, then what we'll try and do is get back to you either by email or phone after the event. Now, I'm going to take you through a standard IVF procedure, what to expect if you're thinking about extending or starting your fertility treatment, and we'll have a few additional bits of information and tips along the way. But before we start, I'd like to set off with an introductory video.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At Care, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with Care was the right decision.
So the team that we worked with at Care were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way, and I feel like they lived the journey with us.
So I've had several treatments with Care, and I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
Okay, so for the next part of the presentation, we're going to go through a few slides to take you through the IVF process. But first of all, care started in my hometown of Nottingham in 1997, and from there we grew from one clinic to two. Our second clinic was in Manchester, and now last year we had, I think it's 23 clinics throughout the UK. This is a map to show where our clinics and our satellite clinics, these are the smaller clinics that feed into our big laboratories, are. So as you can see, we have a pretty wide spread over the whole of England, and also we have one of our largest clinics across the water in Dublin. So at the first step of your journey with care, you would contact our general inquiry team. We have a group of trained individuals who are here to answer our phones, and they're led by our team manager, Shah. So if you have any questions you want to ask, whether you are with us already or whether you're in another clinic, then you can contact us via our general inquiries team. We hope that by the time you've decided to undergo fertility treatment, you'll have had a diagnosis. So by the time you come to be treated, then you'll have a pretty good idea of where the problem lies. If not, it might be that you're coming to the care clinic de novo, having just been trying for a baby for 6 months, a year or two, and just want to find out if there is anything that is going wrong. Do you need any tests, any investigations? And of course, we can do that. We're a dedicated group of clinics. All we do is fertility, and so we're at hand from A to Z in terms of your treatment. We have a dedicated fertility patient portal. So one of the first things that happens is that we will provide you with a portal, and there we can feed you with information. We can talk across the portal. You can ask us questions. We can speak to you. We can provide you with information, fertility tests, the investigations that you need, and the results, so that all the time we're in contact with you, if not personally, remotely on your unique fertility portal. So normally the first port of call is your consultation. So you've decided that you need to take things further. You have a particular anxiety about your inability to conceive at this time in your life when you want to conceive, and so you can phone one of our clinics, and we will put you in our local clinic if that's where you want to go. Here is one of my consultant colleagues, George, consultant gynecologist at Sheffield, conducting a consultation with a couple, as you can see in the picture here. So the IVF process, if that's the treatment that you need, is fairly standard, and it involves 3 or 4 carefully constructed steps. The first thing is ovarian stimulation. That is where we use hormones, injectable hormones, to stimulate egg growth. We don't want one egg. We want to try and get as many eggs produced as we safely can for you. And we monitor the growth. We provide you with the stimulation, and we teach you how to give the stimulation. We watch the eggs growing by scanning you a couple of times over the course of 7, 8, 9, 10 days. And when the eggs are ready, we give you a late night injection, which completes the maturation of the egg and makes it ready for egg collection. And we program your egg collection 36 hours after your final late night injection. As I said before, we have dedicated nurses who teach you how to give the injections to yourself at a time that is convenient for you. And here is one of our senior nurses from Tunbridge Wells demonstrating how the injections are given. If you have any queries or any anxieties, you can always pop into our clinic and we can teach you face to face, or indeed provide you do the injections yourself. But most people, the vast majority of people, are quite comfortable doing the injections themselves. So once you've started the injections, we will monitor the growth and development of the eggs by vaginal ultrasound. This is a vaginal ultrasound machine. The procedure is painless. It's very quick, and we'll do it, as I said, probably monitor the growth of your eggs twice or 3 times during the course of the cycle. This is one of our very senior consultants, Rima, who is the medical director at Birmingham, our Birmingham clinic, demonstrating a vaginal ultrasound machine. The egg collection is performed under sedation, so you're not asleep, you're just zonked out, and you usually get an intravenous injection which makes you drowsy, together with a painkiller. And then you have your egg collection. The egg collection is fairly straightforward. It's quick, and again, it's performed by vaginal ultrasound, and we guide a little needle through the top of the vagina into the egg. The needle doesn't have to travel very far at all, because by this time the ovaries are quite swollen, and the follicles, these are the little fluid-filled sacs in which the eggs grow, are very close to the top of the vagina. And then using the ultrasound scanner, we just guide the needle into each of the fluid-filled sacs and then suck out the fluid, and hopefully the egg is contained within the fluid. The procedure takes about 10 to 15 minutes. Afterwards, you get up, have a sit down and for 10 to 15 minutes and have a cup of tea and a biscuit, and then normally you're able to go home. I would advise that you take the next day off. It may be that you want to take another day off afterwards, because you might be a little bit uncomfortable, but normally 1 day's rest after an egg collection is sufficient. Whilst you're having your eggs collected, your partner, if you do have a partner, is providing a sperm sample. And then what we do is we will examine the sperm and look for the good ones to inseminate the eggs once they've been identified. So I think we've got a video of some sperm moving here, have we? It's just on its way. So this is a microscope view of some sperm swimming. Now, these are clever little devils. They, for a sperm normally to swim from the vagina to the egg is the equivalent of a man swimming from Liverpool to New York at 600 miles an hour. They've got a long way to go. But of course, during IVF, these sperm are actually placed right next to the egg. They don't have to swim all the way across the Atlantic. We just put them right next to the egg, and all they have to do then is swim into the egg. There are certain circumstances, though, where the sperm count may be quite low, and we may have concerns that the sperm may not be able to swim into the egg. And in which case, in these circumstances, we will inject, or my clever embryology colleagues will inject a single sperm into each egg. And this is called ICSI, intracytoplasmic sperm injection. And as you can see here, that needle with the sperm in it is the size of a human hair. And the sperm has just been drawn up, and as you can see, it's now being injected, the single sperm, into the egg. So it'll find its way to the nucleus, and hopefully that egg will fertilize with that sperm and then start growing. So what we do then, the egg and the sperm are put together in what we call a closed incubation system. The sperm and the egg are then left to get on with fertilization, and we will inspect the growth and development of the embryo every 24 hours. At Care, we also use a particular instrument called time-lapse technology. So instead of taking the developing embryo out of the culture medium, we actually video the embryo, and every 10 minutes we take measurements of the growth and development, how quickly they're growing, how quickly the embryos are dividing, and put all that information into an algorithm which we call Care Maps. And we have information on many hundreds of thousands of embryos, and that information is then compared with your growth and development of the embryo, and that gives us an idea as to the chances of that particular embryo turning into a baby. Here is an embryo developing now. Of course, in terms of size, that embryo would sit on the sharp end of a pin. So they are very small. My scientific colleagues are incredibly dexterous in manipulating these embryos. That's an embryo growing and developing and dividing, 3 days, 4 days, and that's coming up to 5 days old, where you get the differentiation in that embryo of the afterbirth and the little clump of cells that will turn into the baby. And that's what we call a blastocyst. A blastocyst is a 5-day-old embryo, and that's what we aim to grow. And we aim to grow an embryo up to 5 days old. Many years ago, we only had the technology to grow embryos up to 48 hours old. But now, with the advancement in techniques and the quality of culture medium, we can grow an embryo in the laboratory for longer. We can't grow it much longer than 5 days because the culture medium the requirements become very complex, and of course we want the embryo to be as safe as possible. And at that point, we will put it back into the uterus. Sometimes the embryologist will feel that the embryo is probably better off in your uterus earlier than 5 days, in which case you might come in for an embryo transfer after 3 or 4 days. But the embryologist will decide how the embryo is growing. Okay, can I have the next slide, please? So here is the Care Maps algorithm, and what we are trying to do is to maximize your chance of success. This particular embryo on the right is being biopsied. So in some cases, what we would advise you to do, or if the circumstances predict that this needs to be done, we will take a small sample of the contents of the embryo and have a look at it and grow it for the genetics inside, to make sure that even though the embryo looks normal and looks healthy, this is a process whereby we can confirm whether that embryo has the right number of chromosomes and is likely to turn into a healthy individual. So once we've got the embryo, we have then got to put it back into your uterus. And this is a technique that we call embryo transfer. In the majority of cases, we then use the vaginal ultrasound machine again to direct us to put the embryo into the best place possible. And here we've got a diagram of an embryo being placed through the cervix, through the vagina, through the cervix, and into the uterine cavity. That's the cavity inside the uterus where the baby grows. So what we do is, under ultrasound guidance, in most of cases, we will put the embryo very carefully into the uterine cavity, normally about 1 centimetre from the fundus. That gives us the best chance of getting a successful pregnancy for you. The technique itself is very quick. Again, it involves a visit to the clinic, It usually takes about 5-10 minutes to do. We like you to have a full bladder in most cases, because the bladder pushes down on the uterus and flattens it out, making the embryo transfer technically easier. Sometimes we don't need to do it, but most of the time we would ask you to come with a comfortably full bladder. As I say, the majority of cases of embryo transfer, it's quick, painless, and easy. That's not the case in all patients, but in the majority. Sometimes patients will have a condition whereby their egg quality is no longer very good, or they may not have any eggs at all. In which case, we would suggest that couples would consider using eggs donated by another individual. We have a dedicated egg donation program that we can refer you to should the need arise, or should you be considering the use of donor eggs. And the same goes for sperm. In some cases where the male partner has no sperm, or in fact it's a single female wanting a baby, we will refer you on to our sperm donation team, who will then take you through the rudiments of egg and or sperm donation. At all points in the fertility journey, we know how stressful fertility treatment can be. Not only is infertility itself a very stressful condition, can be a very stressful condition, but the treatment itself can also be stressful, particularly when you're going through it. There's lots of questions you want to answer. There's lots of anxieties you have. So we believe it's important that there is somebody there for you at all stages for support, answering your questions, and it doesn't matter how trivial you think they are. If they're important enough to ask, they're important enough for us to answer. We have a number of ways that we can do that. We have a care buddy scheme. We have our own nurses, dedicated nurses in the clinic who are overlooking your treatment, or if you feel the need to speak to a doctor can always get back to you, depending on the questions you have to you want asking. To some people, fertility treatment is not available on the NHS, and if you don't fulfil the criteria for NHS treatment, or you don't live in an area where IVF is provided on the National Health Service, or indeed if the NHS waiting lists are just too long, it may be that you want to consider funding the treatment yourself. And this can be a further stress. You don't know, people will say, IVF is very, very expensive, and it is. Relatively, it's no more expensive than some other treatments that are widely available on the NHS, and sometimes we feel that it's not fair that that a lot of patients have to pay just because, like other treatments, IVF seems to be a low priority on the NHS. It may have a high profile, but it has a low priority. Certainly post-COVID, it seems to have the priority seems to have dropped even further. But we believe to help with that. With that journey, we should provide a seamless treatment protocol, and that involves giving you advice about payment schedules, and we have a particular program called Care Pay that provides exclusive IVF funding programs to manage your treatment. We can do IVF multi-cycle programs, an IVF refund program, and we also have a donor egg IVF refund program as well. We can provide all the information you need so that you have a clear idea of not only what treatment you need, but how much is it going to cost before you start. It can be very concerning if after you start the treatment, there's something that you didn't realise you had to pay for, and plus VAT, plus parts, plus labour, like when you go to a garage, well, for your car to be serviced, etc. We don't want to do that. We want you to have a clear idea as to how much it's going to cost you before you start, hence the care pay. And just again to let you know that we have our care patient inquiry team on full alert. This is the number that we have for you. It's a dedicated line. So if you have any inquiries or if you want to make appointments, just give us a ring and we'll put you in contact with your local clinic. So we've had an awful lot of questions already, and I'm going to do a whistle-stop tour through the first bunch. And as I said, if we can't get through them all, we can always get back to you by email later on. But I'm going to also, as we go through this evening, answer more questions later on. So these are some questions that we had earlier today. Male factor infertility, 57 million, 59% progressive motility, 7% normal. Is this a normal sample, and do I need ICSI? Well, the answer to that one is that looks like a pretty good sample to me. 57 million, anything above, 25, 30 million is good. What we want is 35 to 40% doing front crawl. You've got 59%. And believe it or not, we only want 96% of our sperm is abnormal. Only 4% tends to be normal, and that is normal for humans. And in this case, we have 7% normal. That's a normal sample. So obviously, you would need to speak to your consultant in your clinic, but I would say that doesn't need ICSI. It just needs straightforward in vitro fertilization without ICSI. That's it. Instead of injecting the sperm, we just put the sperm and the egg together and leave them to get on with it. When we do embryo transfer, do we do so straight into the uterus? Well, the answer to that is yes, if we can. So we thread the embryo through the cervix and into uterine cavity, like I showed you just beforehand. There are occasions when, for some reason, the cervix isn't open, or it's stenosed, or it's been removed because of surgery. A particular example is cancer surgery. Sometimes patients will not have a cervix, or the opening is so stenosed or closed over that we have to find alternative ways to get the embryo into the uterus. And this is where the benefits of having highly skilled consultants, dedicated to fertility comes into play, because we can put the embryo, we need to put the embryo through the muscle of the uterus, or occasionally we can put the embryo through the back door, if you like, through the fallopian tube and down into the uterus through the fallopian tube. And I've done that on many occasions in patients who have had cervical surgery for cancer, etc. There's been no way to get that embryo in other than getting into the uterus via the fallopian tube. Small cysts on ovaries, would this be an issue when starting IVF? Not really. Many cysts, small cysts, are just functional. They are normal. They come and go. That's what happens with a normally functioning ovary. You grow little tiny cysts, they pop, you grow some more, because the ovary is alive and releasing eggs and then healing and then releasing another egg. So you occasionally get little cysts, what we call functional cysts, that will grow and become 2 to 3 centimeters and then pop. Occasionally, cysts can cause a problem if they get to beyond 5 centimeters, or indeed they have another cause, not just a functional cyst. It may be a dermoid cyst or an endometriotic cyst. And then it's down to the team as to whether it's in your best interest to have that cyst removed or conserved. Normally, the cutoff point is 5 centimeters. A cyst that is greater than 5 centimeters in diameter, generally speaking, is better off out than in. But everybody is an individual, and we treat everybody as on their individual merits. And it may be that the cyst is better off left inside. But if it's generally speaking, 5 centimeters in diameter is the cutoff to having it removed or just leaving it alone. And hopefully in 50% of them, they'll just disappear altogether. Does PCOS impact egg quality? PCOS stands for polycystic ovarian syndrome. It's a very common syndrome. It causes all sorts of problems. It may be completely asymptomatic. You may have it and you don't know you've got it, and it may not cause you any problems at all. And that's why it's called a syndrome, polycystic ovarian syndrome. A syndrome is a medical disorder that can have a whole spectrum of symptoms and signs, from absolutely nothing to really marked severe signs. And one of the things about polycystic ovarian syndrome is that women who have it, generally speaking, have a lot of eggs. They have more than the average number of eggs, but they are of variable quality. It doesn't mean they're of poor quality, but they'll be variable. There'll be some very good quality, some not so good quality. And this may be a cause for the fertility. It's just that you're not releasing consistently good quality eggs. So in answer to your question, yes, it does impact on egg quality, and that might be an issue. But the saving grace is that women who have polycystic ovarian syndrome tend to have a lot of eggs, and in which case we should be able to find the good quality one that we need to turn into a baby. If my husband is on methotrexate, can we still have a baby? Methotrexate is a very powerful chemotherapeutical agent that we use for various conditions ranging from psoriasis to some forms of cancer. It can have a negative effect on sperm production, but generally speaking, methotrexate, if you take methotrexate, yes, you can have a baby. It can have an effect on your sperm count, but that doesn't mean to say you can't have a baby. So the answer to that is yes. But if your husband is on methotrexate and you are trying for a family, it's a good idea to seek advice, if nothing else, for reassurance earlier rather than later. If you have had a miscarriage and a failed implantation, what other tests can we do, if any? Well, the answer to that is lots of tests. Generally speaking, if you have a miscarriage or you have a failed implantation, the chances are it's due to an abnormality of the embryo. Either the embryo is abnormally formed or it doesn't have the right genetic makeup. So there are two types of tests we want to do. We might want to do tests on the embryo, or we might want to do tests on the uterus. As I said, the problems with the uterus are less common, but it may be that it's a joint problem and we need to investigate not only the egg, but also the endometrium. That's the lining of the womb into which the embryo implants, and the womb itself. There are a series of specific tests that we can carry out on the uterus and on the embryo that can help get to the bottom of the cause of your miscarriage and the cause of the failed implantation. Normally, we wouldn't necessarily do those tests straight away because they can be quite invasive, and if they're not available on the NHS, it can be quite expensive. But as I said before, to each individual, every individual is different, and we need to treat everybody on their individual merits. So a quick word or a consultation with your consultant or nurse practitioner will help to decide which are the best tests, the most economically efficient tests that you need to give you the best chance of not having a miscarriage and not having a failed implantation in a subsequent embryo transfer. Do I need to take progesterone during a modified natural frozen embryo transfer? My answer to that is yes. Progesterone is a very important glue for the enablement of the embryo to stick into the uterus and grow into a baby. So if in doubt, progesterone is a good idea. So my advice to you would be, yes, you need progesterone. Can I breastfeed during IVF, FETs? Well, if you're breastfeeding, the supposition is that you have a baby. Now, breastfeeding is brought about by the production of a hormone called prolactin. Prolactin creates breast milk, and prolactin is one of the world's great contraceptives. When you are breastfeeding well, then the lining of your womb is thin, you don't have a period, and you don't release an egg. That's why in the third world, breastfeeding is encouraged, not only because it's best for the baby, but it's also good for the woman that she doesn't conceive quickly after having had a baby. She needs time for her body to recover. So it's not the best, and I would advise against having IVF when you're breastfeeding, because you are still producing those hormones that are actually contraceptive, and so may have a negative effect on your on your IVF outcome. Of course, you also have to bear in mind that breastfeeding for the baby is also very good on many levels. So you don't want to necessarily cut your breastfeeding short to go ahead with further IVF, because then you may be that may have a negative effect on your offspring. So again, the best advice I could give you is speak to your own consultant about your own individual circumstances, but generally speaking, I would wait till you finish breastfeeding until you start your IVF again. Is Clomid successful for polycystic ovarian syndrome? Clomid is a very powerful fertility drug, and the way it works is you swallow Clomid. It's a tablet, you take it for 5 days, and it cuts off the mechanism by which the brain listens to the ovary. So when you take Clomid, your brain, it cuts off the feedback mechanism between your brain and your ovary, and your brain goes, hang on a minute, my ovaries stopped working. It needs a kick. And so the brain pushes out more hormone to get the ovary to produce an egg. So it really is a sort of an ovary kicking mechanism. Now, if you're not ovulating for whatever reason, that means you're not releasing an egg, Clomid can be a great treatment. And within 6 months, if patients are chosen properly, 50% of women will have conceived on Clomid. However, often Clomid is used a bit of a stopgap. Oh, well, we can't find anything wrong. You might as well take a bit of Clomid, and particularly what we call in unexplained infertility, and that is of no use whatsoever. It does not help you to get pregnant if you have unexplained infertility. Of course, some people do get pregnant whilst taking Clomid, but that's not a cause and effect. That's just coincidence. You would have got pregnant anyway, and it can, in some circumstances, be detrimental. Similarly, ovulating is a you either do ovulate or you don't. So you can't ovulate better. So if you're ovulating on 50% of 50 milligrams of Clomid, there is no benefit whatsoever in doubling that to 100, because you don't ovulate any better. It can actually have a negative effect on your chance of getting pregnant. So, the old adage of using the lowest dose possible to create the maximum effect is no benefit in doubling it. But in answer to your question, Clomid, yeah, it's a really successful drug when used in the right people. So that's all my questions I've got for the first half. So I think we'll carry on with another video, and then we'll see what questions have come through.
I'm Shah, and I manage CARE's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So, if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose care was just, one, the care that they give you, the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of a one size fits all, but with care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to care.
Oh, the support at care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own care family. From our consultants, embryologists, and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
Right, so let's do a few more questions. There are quite a few, and hopefully many of those questions have been answered by our team. But here's a few more that I will go through. I am due to start treatment soon and have been told my medication will be low dose to try and avoid overstimulating my ovaries. However, I'm worried I won't end up with a good amount of eggs with a low medication dose. How successful generally is having a low dose medication cycle? Well, it's been proven beyond doubt that the more eggs you get, the better chance you have of getting pregnant. But over a certain number, it can actually, the chance of success actually can go down. So what we need to do is to get the optimum number of eggs as safely as we can. Now, if we overstimulate your ovaries, then you can run into problems. And one of the biggest side effects of IVF is something called ovarian hyperstimulation syndrome, where the ovaries go absolutely mad and produce lots and lots of eggs. which can be quite detrimental, because not only not only do you get lots of eggs, but you get lots of fluid, and fluid seeps out of your ovaries. You can get clotting problems, and you can get a lot of bloating, and you can end up in hospital quite severely ill. So we want to avoid that at all costs. So in the vast majority of our patients, over 99%, we actually do that. Ovarian hyperstimulation syndrome nowadays is exceptionally rare, but we still have to bear it in mind. So we use, again, as I mentioned earlier, the old adage of using the most effective, lowest dose treatment. And we're fairly clever and knowledgeable about using the best dose which is right for you to get the optimum number of eggs. So my advice to you would be to reassure you, don't worry. We will know your age. We will know your ovarian reserve. We've done the blood tests. We'll have done the scans. So the doctors will be able to prescribe the best dose to give you the best number of eggs as safely as we possibly can. And that's the whole basis of the tests we do, to give you the best chance without running into difficulties with ovarian hyperstimulation syndrome. What's the lowest sperm concentration you need for realistically successful IVF? Well, I've seen a couple have a twin pregnancy where the male has had 5 sperm. Not 5 million, not 5,000, not 500, but 5. So strictly speaking, 1 sperm should do it. 1 good quality sperm should do it. Obviously, if you've got a load of sperm, millions of them, you've got more to choose from. But and your chances may be reduced. But with ICSI, don't forget that ICSI was only first used routinely in the early to mid 1990s. So before 1990, there was virtually nothing we could do for patients, for men with low sperm counts. Nowadays, there's loads, and ICSI, which was introduced in the mid 90s, transformed IVF. And if you've got 1 egg, and you've got 1 good sperm, you put it in, there's your chance. So I would say it can be really, really low. The important thing is to find a normal sperm, just that 1 normal sperm, which is easy to find in a big sample, but it doesn't mean to say that a low sample, you can't find 1. And we get lots and lots of pregnancies in men with very low sperm counts. My partner's normal morphology is 2%. Does this mean that we can't proceed with IVF? Not at all. 2% is one of the reasons why couples turn up at IVF clinics, turn up in fertility clinics, because there is a problem with the sperm. 50% of all heterosexual couples will have a male factor issue. Increasingly in same-sex couples, up to 50% of the patients that we see in Liverpool are same-sex couples. That's obviously we need to use donor sperm. But in heterosexual couples, a morphology of 2%, yes, you can. And what we would normally be thinking of is ICSI, intracytoplasmic sperm injection, where we find a normal sperm and inject it into just 1 normal sperm of normal morphology and inject it into the egg. We don't leave nature to get on with it by just putting the eggs and sperm together and the best ones to begin. We probably pick the best one and inject it in. So yeah, absolutely, that's what we do. This is bread and butter stuff. Normal morphology at 2%. Would a biconjugate uterus have any impact upon IVF success? Well, during the last video, I saw that question, and I just wanted to show you what a biconjugate uterus is. Now, that is a picture of a normal uterus, and that is a biconjugate uterus. It's far more common than you think. It's where the uteruses separate. There are 2 cavities separated by a big muscle layer there. So there are 2 cavities. One there, biconjugate, 2 horns. And as you can see, it has no effect on IVF. The IVF success rate is every bit as good as in the pregnancy in the normal uterus. However, if you were to get pregnant, you'll get pregnant in one of those horns. And the baby, depending on the size of the horns, will not have as much room to grow. So what happens is the baby will grow to a certain gestation and then press on the horn, and that will kick off labor. So one of the commonest complications of a pregnancy in a woman with a bicornuate uterus is prematurity, which in itself can be a huge problem, but it's more obstetric than IVF. So before you go ahead with IVF, what we would do is make an assessment for our obstetric colleagues as to what is the level of the abnormality in the uterus, and what sort of steps we must take to make sure that if there is a discrepancy in the size of the horns, that the embryo goes into the big horn. I remember actually one of my patients emailed me last night, and I remember many years ago having a patient with a bicornuate uterus, and in those days, because we didn't have the technology that we have now, we used to put back more than one embryo, and she had 2 embryos put back, and one embryo was lodged in one horn and one embryo lodged in another. We would never do this nowadays, but this is going back 30 years. And sadly, she conceived with twins, but one baby was born prematurely, the one in the small horn, and didn't survive. And the one in the large horn went on to be going to be delivered at 34 weeks, 6 weeks prematurely. That baby a little boy spent 3 weeks on the neonatal intensive care unit, and he was well enough to go home after 3 weeks. The couple then emigrated to Canada, and I got a photograph on email yesterday of their son passing out at his police cadet parade at the age of 26. I know you don't believe I'm that old, do you? But yeah, that was one of my patients. And thank you very much, Jackie, for sending me that photograph. And yes, I do remember you, and it's great that you have such a strapping son. She went on to have another baby as well, again born prematurely. So these are the things that we go on about, that it's important that you get a full diagnosis from a suitably qualified gynecologist, so you can plan. We can predict all the hazards on the journey to having a family early rather than later, and be proactive. Supplements to be taken during treatment, lots of supplements, as long as they're not harmful, fine. But the supplements that I would say, folic acid, absolutely, unequivocally beneficial. Vitamin D as well. Increasing amounts of evidence suggests vitamin D is good for you, good for a pregnancy. You may want to supplement your diet with other vitamin supplements. Not necessary if you've got a good diet. Stop smoking, because that wrecks your vitamin metabolism, and does lots of other things for babies as well. So don't get too hung up about vitamins. Folic acid, vitamin D. What is a good AMH? AMH, anti-Mullerian hormone, is the hormone that's released by your eggs. The more eggs you've got, the more AMH you've got. It doesn't tell you about the quality of the eggs. It only tells you about the quantity. The more AMH you've got, the more eggs you've got. It doesn't give you an indication as to whether you're going to have a baby. It just gives you an indication as to how many eggs you might have. But don't forget that women are egg warehouses. So if you're 35 years old, you have 35-year-old eggs. If you're 20 years old, you have 20-year-old eggs. So in some circumstances, it's better to have a low AMH and be 20 than a high AMH and be 35. That just means that at the age of 20, you've got a lower number of young eggs. So AMH it depends what your age is. Age is a far more important indicator of success of IVF than your AMH, but together they can complement each other and give us an idea. But it's a combination of AMH, age, weight, all those sort of things matter. Normally, we would say you know, a good AMH, I don't know, it depends on your age, but 10, 12, something like that. My AMH is 31.8. My partner sperm count is 0 morphology. What do you suggest? Well, again, AMH 31.8. That's a good count. You've got a lot of eggs. But what's more important, how old are you? Do you have a lot of 45-year-old eggs, or do you have a lot of 20-year-old eggs? But 31 is a good start. But my partner's sperm count is 0 morphology. What do you suggest? Well, in that sperm count, that means that none of the sperm that have been looked at are normal. It depends on your count, it depends on the motility, and it depends on having a look at another sample to see whether we can find just the one or the 1,000 eggs, sperm that may be of normal morphology, in which case we might be able to freeze them and save them and then get another sample and find some more. But if you've got 0 morphology, then you need to see a specialist, male factor specialist, of which we have plenty in Care Fertility, who'll be able to advise you accordingly. Would ADHD stimulant medications need to be stopped when trying to conceive? Do you know what? I don't know. I don't know what Concerta is. I'd have to look it up. But if you were coming to my clinic with ADHD, we'd have to weigh up the pros of stopping against the cons of stopping. And the first thing I would do is to look and see what the potential side effects of Concerta are, because you know what you also have to remember in these sort of circumstances, the disorder itself could cause complications. So using epilepsy as another example, it's far better. People say, well, epileptic drugs can cause abnormalities to babies. Well, that's true, but so can epilepsy. Epilepsy can cause real problems if you suffer from a fit and not taking any in pregnancy, and you're not taking the medication. So it's a balance of whether the disease itself could cause more complications than the treatment, and that's the conversation that we would have to have. You have mentioned Clomid, but letrozole is better if I want. But is letrozole better? Not necessarily. They're both as good as each other. Some can work differently in others than others. So again, you need advice as to your individual circumstances to which one is best for you. Clomid is the old tried and tested one. Letrozole can be every bit as good. Depends on the circumstances. Does DHEA help, and can you use it if you become pregnant naturally, or do you need IVF to have any effect? DHEA is dihydroepiandrosterone acetate, and it's a building block for estrogen. So the idea is that DHEA is the fount of eternal youth. You take DHEA, it increases your estrogen. It somehow improves your egg production or your egg quality. DHEA doesn't do you any harm. It's never been shown to do anybody any good ever. But if you feel as though it's helping you, if you feel as though you want to supplement your medication with DHEA, it's not harmful. And you know, we like lots of supplementary and complementary therapies, even though they haven't been shown to be of any benefit. But the key is, as long as they're not harmful. You know, I love reflexology. It helps my back problem. It's never been demonstrated scientifically to be of any benefit. It's certainly not harmful, and it does me good, and it makes me feel better. So I do it. And that's exactly the same as many aspects of fertility treatment. As long as it's not harmful, you decide yourself. And of course, what you also have to remember is that it may not be medically harmful, but it may be financially harmful. DHEA is cheap. So you pay your money. Would I take it? No, not really. But do you want to take it? If you feel as though it's helping, but it's not going to improve your chance of getting pregnant. And I think, there's more and more coming in, but I think that I think we're running out of time. We've done an hour, and so we've come to the end of our Path to Parenthood virtual information email. I hope some of the information has been of benefit to you. If, as I said before, we have a dedicated helpline. We have a general inquiries team led by Shah, who you saw earlier, who are here to help you. And all I leaves me to say is if you're in a position where you're wanting fertility treatment or wanting to have a family, good luck. We are here to help. And if you think that we can be of help, just give us a call. Thanks again.
One in 6 people need help to grow their family. You're not alone. And our Care family will do everything we can to help your dream of family come true. There are over 50,000 Care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.